Hello dear colleagues, welcome to retinara.org, a vitreoretinal knowledge-sharing platform. In this video, we will present a case with autosomal recessive bestrophinopathy. This case shared by Dr. Kemal Tekin, whose Instagram accounts are at dr.kemaltekin and at retina.academy. This was a 30-year-old male who was admitted with a history of low vision. The patient was healthy without any known systemic and ocular disease. The patient was a product of consanguinity marriage, in which the parents of the patient were a second-degree relative. The BCVAs were 20/70 and 20/30 for the right and left eyes respectively, and the intraocular pressures were within normal limits. The refractive errors of the patient were 0.150 diopters for the right and 1.25 for the left eye, besides he had unremarkable anterior segment biomicroscopy findings. Dilated fundus examination demonstrated centrally hyperpigmented macular scar in the right eye and focal hypopigmented RPE atrophy at the inferior of fovea in the left eye, in addition to bilateral multifocal subretinal white-yellow deposits in the macula and posterior pole of both eyes. Spectral domain optical coherence tomography scans of both eyes revealed minimally serous retinal detachment, with hyperreflective dome-shaped accumulation at the level of retinal pigment epithelium indicating lipofuscin islets, besides elongated photoreceptors and retinoschisis in inner nuclear layers. Fundus autofluorescence exhibited that the central hyperpigmentation was hypoautofluorescent, while its surroundings were hyperautofluorescent in the right foveal region with mixed or decreased autofluorescence at the inferior of fovea in the left eye, as well as the subretinal white-yellow deposits were brightly autofluorescent in both eyes. Fluorescin angiography imaging showed that the central hyperpigmentation was hypofluorescent due to blockage, while its surroundings were window defect hyperfluorescent in the right foveal region, with the window defect hyperfluorescent at inferior of fovea in the left eye, besides the staining of the subretinal deposits in both eyes. In the light of these findings, the preliminary diagnosis was autosomal recessive bestrophinopathy. Why? Let's take a glance to the tips. First, the consanguineous marriage, which is not essential in every case, but autosomal recessive bestrophinopathy is more likely to be associated with homozygous pathogenic variants due to consanguineous marriages. Second, most of the patients with autosomal recessive bestrophinopathy have hyperopic refractive errors, and sometimes with accompanying narrow anterior chamber and even angle closure. Third, multimodal imaging findings. Multifocal yellowish subretinal deposits in fundus examination, and their hyperautofluorescent appearance in fundus autofluorescence examination is very important. Additionally, serous retinal detachment with elongated photoreceptors and hyperreflective dome-shaped deposits at the level of RPE, sometimes with accompanying retinoschisis and/or cystoid macular edema, can be other important OCT tips for the diagnosis of autosomal recessive bestrophinopathy. Of course, it is important that these findings are detected in both eyes. As known, genetic diseases have bilateral retinal features. Finally, to support the diagnosis, electrooculography was performed. The electrooculography showed the absent light rise and decreased Arden ratios, which were found as 1.18 for the right and 1.08 for the left eye. Decreased Arden ratios and absent or reduced light peak in electrooculography is another important clue for autosomal recessive bestrophinopathy. However, it should be remembered that unlike from autosomal dominant Best disease, a normal electrooculography may rarely occur in the presence of a classical fundus appearance in autosomal recessive bestrophinopathy, and unaffected family members who do not have fundus findings have normal electrooculography results. For the definitive diagnosis of autosomal recessive bestrophinopathy, which is caused by compound heterozygous or homozygous mutations in both alleles of the BEST1 gene, genetic analysis was performed and homozygous mutations in PARG2555GLN were detected. Since autosomal recessive bestrophinopathy can be presented with a wide spectrum of ocular abnormalities that may not be easily diagnosed, some misdiagnosis may be made for these patients. It has been shown that the most common misdiagnosis for autosomal recessive bestrophinopathy was central serous chorioretinopathy, followed by fundus flavomaculatus. Multimodal imaging, particularly fundus autofluorescence, is rather crucial to distinguish autosomal recessive bestrophinopathy from these diseases. Electrooculography is an important ancillary tool in autosomal recessive bestrophinopathy diagnosis. Electrooculography of autosomal recessive bestrophinopathy patients characterized by reduced or absent light rise and decreased Arden ratio. However, a normal electroculography may occur in the presence of a classical fundus appearance.
You can share your interesting and educational cases on our website, retinara.org. Don't forget to click the like button and follow our channel to be informed about our new posts.